With women, as we age, it's very important to remember that testosterone is actually the most abundant hormone in our body. Men have more of it, but it's the most abundant in our body. And it's forgotten because it's seen as a male hormone. But testosterone is vital to so many things that we do. Libido, motivation, I call it the get stuff done hormone. You're not going to want to do anything unless you have adequate, optimal levels of testosterone. And then, yes, there's the muscle building aspect. I see that all the time. It's one of the main complaints that I see on an intake form of patient symptoms, weight gain being at the top, fatigue, and then yes, loss of libido and loss of muscle mass or the inability to put on muscle is absolutely on there. And that comes down to testosterone.
Something came up that I have not talked about on the podcast before as it relates to thyroid hormones. And so talking about T1 and T2. And so for listeners that are listening, they're saying, I don't know what you're talking about. I know I've heard Cynthia talk about T3 and talk about T4. We do indeed have other thyroid hormones that are impacted in our physiology. And so maybe we'll start the conversation there, kind of touching on what we know about T1 and T2. Is this something that we need to be concerned about in your clinical experience? What has been like the research that you found has made it more compelling for you to consider having these conversations? Because as I was saying to you before we started recording, many years ago, I used to think, oh, everyone needs to have natural desiccated thyroid and no one needs synthetics and synthetics are bad. And now I feel very differently. I think it's very bio-individual. Mm-hmm. And so when you're getting the T1 and T2, that is likely coming in the form of these natural desiccated products as opposed to synthetic T3 and T4. So for people that are listening, they're like, I don't know what you're talking about. Let's unpack what this represents so that we can better understand this.
Absolutely. And just like you, I've been focused on T3 and T4 and talking about that for years now. And it really, I mean, if I go back about 15 years, that's when I started my research on T2. So through those years, over the last 15 years of using T2 myself, using it with patients, really kind of diving more into the research, the studies, that's what brought it to the forefront for me to look deeper into and to start using a little bit more as a very, very therapeutic, natural plan, a therapeutic protocol to get people to that next level in terms of metabolic rate, energy, all the things that the thyroid does. So yes, let's unpack. We know there's T3 and T4. When we're talking about the thyroid gland, we know it produces 4 hormones, but we focus on T3 and T4 because that's what's in the medication. That's what's in NDT. That's what's in your Synthroid. That's what's in your Cytomel. That's what is in the medication that you get if you are hypothyroid. But we forget about T1 and T2. Those are also 2 thyroid hormones that the thyroid gland produces. And when we look at natural desiccated thyroid, which is the dried out thyroid gland of a pig or a cow, usually a pig if it's Armour NP, we see that it does contain T1, T2, T3, and T4, but we have to look at the ratios there. So when we're breaking down each thyroid hormone, T1 is actually pretty inactive. It's kind of along the lines of T4, although it's even less inactive than T4 because it doesn't even convert to anything. It just kind of stays there, hangs out. That's T1. Then we move on to T2. And it turns out that that is very biologically active and it works on a pathway to increase your basal metabolic rate. And it works on the mitochondria. So it works at the mitochondrial level instead of at the thyroid level, which I'll get to that in a second, in that it stimulates ATP. It stimulates brown adipose tissue, which also helps us with fat burning. So we'll tie this all together into metabolism. And it actually helps people have better energy through the day, but a nice steady energy, not a kind of jacked up, jittery energy. When we move on to T3, we also know T3 is active. That's what really gets to the cell. That's what every single cell has a receptor site on it for, T3. That's what's going to give you an even better metabolism and better mood. And it's going to improve all thyroid functions because that's the active thyroid hormone. And then we have T4, which is inactive, but T4 converts to T3 most of the time. We always have to watch out for those non-converters, and we're looking at your reverse T3 numbers to see how well you are converting that T4 to T3, but it has some effect on the body. All of those thyroid hormones are good. All of them are in, like we said, natural desiccated thyroid. But when we're really looking at making an impact on you as a person, on your symptoms, that's where we have to focus on the T2 and T3. And when we back up and look at the history of and kind of where this came about and how it even piqued my interest, I have to go back to bodybuilders because they are the OGs of biohacking. They really are. If you look at bodybuilders, and whether you're talking peptides, SARMs, certain supplements, even creatine, which we'll talk about today, bodybuilders started it, right? They started using it first. So when we look back at T2 and T3 in the bodybuilding world, so this is where I'm going back 15 years, we see that, okay, if we are honest, bodybuilders will abuse medication, i.e. T3, in order to lose body fat. The smart ones, the trainers to the pros, the ones that are at the top of their game and they're producing these bodies of perfection that are getting their pro card and moving on to greater things. They knew better. They knew that abusing T3 is going to result in muscle loss as well as fat loss. Abusing T3 is going to shut down that competitor's thyroid gland. And now they're going to have a problem after that show's done. They would use T2. They would use T2 because it doesn't burn muscle. They would use T2 because it doesn't have an impact on the thyroid gland itself, and it won't make a person hypothyroid or produce that negative feedback loop that thyroid medication can produce. So we have to tip our hats to the bodybuilders because they figured this out a long time ago. And now we see it moving into mainstream.
Well, and it's interesting because as an example, I've been on this thyroid replacement journey ever since my non-desiccated product was pulled off the market in 2020. And we tried everything. When I say we, my functional medicine providers, who I am not being critical of them at all. They have done the whole scope of things. But first it was Synthroid, then it was Cytomel, then it was Synthroid and Cytomel, then it was increasing levels of Cytomel because it was, if your T3 is not doing anything, the thought process is give more. Mm-hmm. And at one point, I think I was taking, I want to say 20 micrograms of T3. I mean, because it was just like, hit it harder, hit it harder, hit it harder. And finally I said, maybe we're giving so much that it's suppressing this feedback loop. And my body's like, we don't need to make any T3 because we're getting so much exogenously. So I think you bring up a really good point that, maybe the bodybuilders who in many instances probably don't get the respect they deserve, because you are right. They are these ultimate biohackers and been doing these things for a long time. And this is where I think T2 is particularly interesting because for so many of us, like now I'm on compounded. I mean, it's got to the point where I'm on this crazy compounded dose that finally my nut levels are where they should be. It's taken 2.5 years, and it is not because of intermittent fasting. People always ask me that. And I was like, I did really well on my non-desiccated product. And as soon as that was taken off the market, it was unavailable. That's where this journey started. And I had to find the right thing for me. So if you haven't yet found your right thyroid medicine, keep searching, keep looking for that right provider. They are absolutely out there. I just have someone that's like so attentive to detail. Like we were doing microdose changes every 2 weeks to get me to a stable point. And now he believes this is like my happy dose. So I'm on this crazy dose. I say crazy because I've never heard of anyone being on a dose that's, the split between T4 and T3, but it's what works for my body and it's within a therapeutic range, but it's completely compounded for my body. So I know you're probably going to ask, what am I taking?
I am.
It's 37 micrograms of T4 and 4 micrograms of T3.
That's not that much either. I mean, that's just, it's amazing that that's working so well for you because it's not that much, but you're 100% right, Cynthia. You have to find the blend and the dose that is going to work for you. And it really is about symptoms.
Right.
When your symptoms are relieved, at the end of the day, I don't even care what's on paper on those numbers. If you tell me I feel my best, I am symptom free, I am living my best life, then that's your optimal dose.
Yeah. Well, and the other thing that I want to tie into this, and I have to thank you for our conversation that we had the last time we were talking on the podcast, low dose naltrexone. Even though I have negative antibodies, we know that it has this anti-inflammatory effect. And, my functional med doc, who's a friend of both of ours, so if I told you his name, you'd know who it was.
Right.
And he said, if it's going to work, it's going to work. And if it's not going to work, it's not going to work. So let's just try it. And so I just said, I feel good. I mean, it didn't do anything to my antibodies, which have always been negative, but I said, if this is what's reducing the inflammation enough for my body to be like, okay, we're going to accept that we're on this thyroid replacement therapy, and now we're in a happy place. And so for everyone listening, I probably should take a photo for everyone of the bag. I've kept it because it's unbelievable, of 20 different medications I've been on for my thyroid in the last 2.5 years. I should take a photo and then I should just properly dispose of them. But to me, it's really been astounding, even as a clinician, just how challenging this can be. So getting back to this T2, because I think this is really interesting. You mentioned it plays a role in metabolic function, enhancing fat loss and weight loss by increasing calories burned at rest. There was one research that I looked at. It looked like there were quite a bit of rodent studies. And then there was one bit of research which cracked me up. This was 2 euthyroid, so meaning people that have a healthy thyroid amount, 2 human subjects. We know this is not statistically significant, but still interesting. T2 treatment for 3 weeks yielded 4% loss in weight, and resting metabolic rate increased substantially. And so I thought this was interesting. Of course, it's just 2 people. It could have been attributable to a lot of different things, but I think it opens up the opportunity to say that I think that if we're only going to look at T3 and T4, we may potentially be missing opportunities for other people, because how many patients do you know that I saw in the hospital, I saw in clinic, that would say to me, you cannot touch my Synthroid dose. I will not take generic. This is the only thing that works for me. And then you ask them how they feel, and they're like, not great. Right. And so I think there's this mindset of, you're going to go on thyroid medication, it's going to fix everything. And sometimes it takes a bit of time. Sometimes it's not the right medication. But again, this T2 discussion, I think, is really interesting. And so when you're working with your patients, when do you introduce the T2? Is it when they've already been on medications? Like, clinically, where are you finding the greatest benefit for your patients?
If it's someone that's struggling with weight, and normally the thyroid patient is, normally, I say 9 times out of 10, it's that woman that has done it all. She's done the diet. She's done the intermittent fasting. She's worked out. She's worked out twice a day. She's done every workout under the sun. She's taken every supplement under the sun, right? And she still can't lose weight. No metabolism whatsoever. I'll do both at the same time. So I'll start optimization in thyroid medication, and I'll also start her on T2, since that's over the counter. It's not a prescription. And then that way we're hitting both lines for her metabolism. We're optimizing her T4 and T3, preferably optimizing the T3 that T4 converts to T3. We're optimizing her reverse T3. We're taking down inflammation or taking down antibodies if those are present in the case of Hashimoto's. And we're using T2 to work at the mitochondrial level to increase her basal metabolic rate, to stimulate that brown adipose tissue. And that's going to help with the metabolism as well as her energy. So we're doing both at the same time. And it all comes back to, because that T2 does not have a thyromimetic effect. It's not going to make her numbers look like she's hyper. So we know that if somebody, and you probably experienced this too, as you're going up in T3, if you test your T3 levels, your free T3 levels, they're going to be a little bit elevated. And especially if you test without leaving that 18 to 24-hour gap between your last dose of T3 and your testing, you could come back and actually appear hyper on paper. Now, you might say, listen, I'm not hyper. I'm still gaining. I'm still tired. I'm still losing my hair. No way I'm hyper, but on paper, you look hyper. Well, that's the problem with using T3 or increasing the dose of T3 in your case, because you're going to appear hyper. And then maybe, hey, over time, you might actually go hyper. I've had a couple patients that they were on this really nice dose of T3 and they reach out and they're like, you know what? All of a sudden my heart rate's through the roof. I'm jittery. I'm anxious. I'm not sleeping. So what do we have to do? We have to dial back that T3 dose. With T2, we can just leave it there because it's not going to make them anxious. It's not going to make them jittery. It has no cardiovascular effect. So it's not going to increase their heart rate or send them into a tachycardia situation like T3 can. It's just going to be there doing its work at the mitochondrial level, increasing the basal metabolic rate. So it's really safe to do at the same time.
It's really exciting because I'm one of those people when I first started thyroid medicines and I did not want to go on thyroid meds. In my mind, it was like giving up. And so if you're listening to this and you're thinking that way, I fought my provider for 6 months and then I was so exhausted. I finally went on it. It was like someone had turned a light bulb on. I'm like, why did I suffer for 6 months? This is silly. But I think what's really interesting, and Dr. Sarah Gottfried introduced me to this term, so I want to give her full credit, thyroid pause. So understanding that in perimenopause and menopause, your thyroid is going to take a hit. It is not you not doing things the right way. Like someone on, I think it was on Twitter, it was a male, and I'm not anti-differing opinions, but he was talking about how proud he is at 60, he's not on any meds. I was like, that's great. I wish I could say the same, but I take things to support my thyroid. I take things to support my, my sex hormones. And he was like, well, can't you just change your diet and your lifestyle? I was like, who do you think you're talking to? I think you get to a point where you're like, there's no shame in taking hormone replacement therapy, whether that be thyroid, whether that be testosterone or progesterone, estradiol, or whatever constellation of things that you need to make you be able to function and feel good. And so I wanted to make sure that I mentioned that we, I was referred to as the three-legged stool. As we go into perimenopause, it's like our sex hormones, our adrenal glands, and our thyroid really take a big hit. And so if you understand that as you transition from perimenopause into menopause, if you need medication, there is no shame in needing medication. If there's a supplement that's going to make you feel better, I'm all for it. But I think the narrative around medication being a bad thing, that needs to end. It's not as if I'm saying, there's no harm in long-term blood pressure medication or diabetes medicine or high cholesterol medicine. Like obviously those are oftentimes lifestyle mediated. That's a little different. And we would still advocate that women, prioritize their sleep and manage their stress and lift weights and try to prioritize protein. Like those lifestyle things are still important for everyone. But the shaming that goes on, I got blasted on Twitter a couple of days ago for this. And I just said, I'm sorry that you don't understand, but I can't do things better than I am. And that's sitting from a place of judgment. And I'm telling you as a clinician, most of my patients are taking hormone replacement therapy in one capacity or another. And let's stop shaming women for advocating for themselves.
Oh, 100%. If I can jump in there too. That pisses me off to no end because hormones give us life. And that's what these people on Twitter blasting you don't understand. Hormones literally give us life. You're doing hormone replacement, again, whether it's sex hormones or even thyroid, to prevent bone loss, to protect your brain, to protect your heart. And because you do all the things to take care of yourself and you don't want to lose all of your hair, gain weight for no reason, have dry, wrinkly skin, have pain during intercourse, all of those things that come with declining hormones. So I always tell my audience or my patients that are, kind of on the fence. And they're like, I don't want to be on a medication, quote unquote. I said, you're going to be on hormone replacement. So if we're using NDT, if we're using Synthroid, we're using Cytomel, if we're using testosterone, progesterone, estradiol, we're replacing hormones that are no longer being properly made by your body. If you had type 1 diabetes and I said, you need to go on insulin because your pancreas isn't producing the right amount of insulin, would you be like, you know what? No, I don't want to be on medication. No, we would be like, well, then you're going to die because you need insulin. You need hormones the same way that you need insulin as a type 1 diabetic. You're not going to die without them, but you're not going to live a good life without them either.
No.
So we have to kind of separate the whole medication versus hormones into two separate categories.
Yeah. And it's interesting. And for full disclosure, earlier this year when I was meeting with my functional medicine doc, we did a slew of inflammatory markers. And he said, this is exactly why women make this assumption in menopause. He wasn't being judgmental. He's just being factual. He said, you do all the right things. and look at the degree of inflammation going on in your body. Because I had a period of time where I stopped my estrogen and my testosterone because I was on way too much for my body and I didn't feel good. And so we had to kind of start from scratch. And I said, this is 6 months without, I was on progesterone the whole time, however, because I was like, they'll have to pull that from my cold, dead hands. There's no way I'm giving that up. But it was very interesting to see how that impacted my cholesterol, how that impacted inflammatory markers in my body. And I just said, I don't feel bad, but this is a common misconception that women say, I don't feel bad, so I don't need HRT. And I'm like, you don't, I mean, I will be totally transparent. I will share all my labs with people if they have a desire to see them. This is what it shows on a cellular level, the degree of mitochondrial stress, the degree of oxidative stress and inflammation that's going on. We know that menopause is a disease state, whether we like being told that or not, it really is. And I think that the sooner we kind of think about it that way, it makes sense to consider. And obviously, I know I have listeners that may not be in a position to be able to take HRT. We've got some, cancer survivors, and they're just not in a position to be able to do that. But for everybody else, just get that fully informed consent. Work with a provider that can go over the pros and cons with you, and then you both collectively make a decision for yourself. But to think that you have to ride out a dry vagina and no sleep and brain fog for the rest of your life. I mean, I was talking to a nurse who's 10 years into menopause, and she's a nurse. I'm just going to keep saying this. She's a nurse. And every GYN she saw was like, yeah, you need to lose weight. And she was like, I understand, but you don't understand. I eat very little. This is how much I exercise, and I can't sleep. Like, I literally wake up 10 times a night. And so, with some advocacy work, she's now seeing a different provider and she's finally sleeping. But she said, if I hadn't been listening to your podcast or, Amie, your podcast, some women just wouldn't know. They would just accept what they're being told. And I think there's no other way to put it. I think it's really criminal that women don't need to suffer in middle age. Now, I want to make sure that we touch on cholesterol because this question came up quite a bit. I know when I was working in clinical cardiology, the first thing I would say if someone had a grossly abnormal lipid profile was, what's going on with your thyroid? Or if you're insulin resistant, what's going on with your thyroid? So how does thyroid hormone play into cholesterol levels and looking at our lipid panel results? Because I think for many people, this is why I'm like, thyroid it's like thyroid plays with everything. We have to make sure that we're looking at all these pieces. But when you're working with your patients, how do you talk to them about the interrelationship of their lipids and their thyroid function?
So we always talk about the triangle. So the thyroid is at the top, and then on one side down on the triangle, we have insulin. On the other side, we have cholesterol. We know that thyroid, being the master gland, is going to control the insulin response. So you could have high insulin, high glucose. You could look like a diabetic, even when you're eating perfectly, if your thyroid is off. And then on the cholesterol side, we have a direct effect of the thyroid being off to wonky cholesterol numbers. And we also know that high insulin and being insulin resistant will drive up cholesterol. And by the way, it's the white, and I'm sure Cynthia said this many times, it's the white stuff. It is the processed foods. It's the sugar, it's the flour, it's all of those carbohydrates that drive up our glucose, that drive up our insulin, that really has an impact on our cholesterol. It's not the red meat, it's not the egg yolks from, the 90s. It is the white garbage that we're putting into our body that is driving up cholesterol. So now you throw on a dysfunctioning thyroid or a non-optimized thyroid on top of that. Now you have crazy cholesterol numbers. And when I say crazy, listen, we all know that the cholesterol cap, so that standard lab value range, has been reduced. It used to go up to 300. Now it's squished down to 200. So you get that little H next to your total cholesterol if you're at a 230. Would I worry about that? Absolutely not. I have had super healthy patients living into their 70s, water skiing, exercising, hiking, walking around with cholesterol numbers in the 400s. Their arterial scans are beautiful. They have no issues whatsoever. So we have to take cholesterol and that lipid panel and pair that up with each individual and say, is there a risk factor here? What's the history? What's the CRP? How much inflammation is going on? Are they taking care of themselves? But at the same time, we have to go back to the thyroid. You have to check the thyroid because if that is off, then you are going to have dysregulated insulin and crazy wonky cholesterol numbers, be it the triglycerides, the LDL, usually a lowering of the HDL, the good protective cholesterol. And then unfortunately, those are the people that get the Band-Aid. Those are the people that get the statin prescribed to them, and they have all the side effects of the statin. It's like, if we just optimize the thyroid, you wouldn't need this Band-Aid.
Yeah, I think it's a good point. And it's interesting. For 16 years, I worked in clinical cardiology, and probably the last 4 or 5 years, I would start reducing statins on patients who didn't have documented active coronary artery disease. And I would document why. And I would say a total cholesterol of 100 is a marker for morbidity and mortality, because there are a lot of things that cholesterol does in the body that I think people forget about. Like, they don't understand that that's where we derive our sex hormones from. And if your total cholesterol is 100, I bet you have no libido. And so all these poor patients of mine, most of whom were men, just by pure happenstance, and having conversations, I would say, you're on 80 milligrams of Lipitor. I think it's time to reduce it, and explain why. And they were like, oh, this is great. But the understanding that, if you need to go on a statin because you have documented cardiovascular disease or peripheral vascular disease or carotid artery disease, we're not telling anyone. We're not telling anyone to change anything that you're doing. Right. We're just suggesting that make sure your providers are looking regularly at fasting insulin, that they're looking at your fasting glucose. And I'm just going to plug this stat that I have been talking about on social media the last 2 weeks. A fasting glucose in the 90s is not benign. I think we have this misconception that a fasting glucose in the 90s is benign. It is not benign. I'll tell you why. Dr. Robert Lustig, who I hold in high regard and has been a podcast guest and wrote an amazing book called Metabolical, talks about the fact that if your fasting glucose is between 90 and 99, you have a 30% increased likelihood of developing insulin resistance. So if it happens once, I wouldn't stress about it. But if you're noticing a trend and you're noticing a creep, and you're checking your glucometer in the morning, and every time you wake up, your fasting blood sugar is 98 and you think it's great because it's less than 100, you've got work to do. So I want to just make sure I plug that in. I've been talking about it more often because that metabolic health piece, I think, is so, so important. Thank you so very much for talking about this thyroid piece. Again, if you're being told you need to go on lipid lowering medication, I would make sure your provider is ensuring you're not insulin resistant and that you don't have an underactive thyroid, because if you do have an underactive thyroid, that can skew the results that you're looking at. I can't tell you how many people I would say, I'm not going to put you on medication until we figure out what's going on with your thyroid. And they were almost always very appreciative. Of course, I had a couple of people jump in the gun. They're like, nope, I want to be on that lipid lowering agent. No, you don't. Let's make sure that you don't have something that's reversible that we could adjust and fix that. Okay. Absolutely. I want to touch on medications just one more time, because I think this is so important. When we're talking about T3, I think it's really woefully misunderstood. I think that kind of the conventional endocrinologist is putting patients just on Synthroid, which we know is synthetic. And there's no shame if you're on synthetic medications. That's not what this is about. On synthetic T4, with the assumption that your body can convert T4 to T3. So T4 is inactive, T3 is active. Talk to me about how you make a determination between Cytomel, compounded T3, like what are the indicators for you clinically? And then help us understand where T3 is converted in the body, because I think everyone assumes the thyroid does it all. And yet this peripheral conversion is also super important.
Right. So like you just said, T4 has to convert to T3, T4 inactive, T3 active. So we just keep that in mind. That conversion process is very long. I always say it's like running 5 Tough Mudders that your body has to do, because everything has to be in alignment. There has to be, you can't be insulin resistant. You can't be estrogen dominant. You better have adequate levels of iodine, magnesium, selenium, and zinc, vitamin D. You better not have a genetic SNP, the DIO1, DIO2 SNP that impairs conversion. And there is a marker that we can look at. It's called reverse T3. And we can see whether you are adequately converting your T4 to T3 or whether there's some issues along the way. Now, of course, we're going to address the issues. We're going to look at all of those things that can interfere with conversion of T4 to T3 and address those. But at the same time, sometimes it's just a change of medication that's required. So I have a stat for you. This is interesting. And I've been saying this stat for the last couple of weeks. 2%, only 2% of hypothyroid patients, and I might even argue that that's high, do well on T4 only. 98% of hypothyroid patients do well on a combination of T4 and T3. So we know that giving a little bit of T3 is very, very beneficial. Number one, you skip that middleman, you skip that need for conversion, and you give the cells exactly what they need. You give them the T3 that they have a receptor site on for. Your cells do not have a receptor site for T4. So when your doctor gives you T4 only, you are literally crossing your fingers and wishing on a rainbow that this is going to help you, that this is going to convert perfectly over to T3 and then get to your cells to give you that symptom relief, to give you metabolism, grow your hair, strengthen your nails, allow you to poop every day, clear your brain fog, all the things that the thyroid does. How we determine what direction to go with medication is just so individualized, but I'll give you a couple scenarios. If you have someone that is on T4 only, which I see all the time, and we look at their reverse, if that reverse T3 is above a 12, that is indicative. And these are functional values. This is not what you're going to see. You're not going to see it flagged on your labs. If you come in at a 14, a 16, even a 20, you're not getting flagged in your reverse T3 until you're above a 25, which then there's some real significant conversion issues going on. So if someone comes in, they're on T4 only, the reverse is above a 12, then we know, listen, we have to drop that T4 dose a little bit. We got to pull back on that, address any factors that we see that are impairing conversion, and then add in a little bit of T3. Now, if this person isn't doing well on their Synthroid, on their Levo, maybe we do change them over to natural desiccated thyroid. And here's the beauty of thyroid treatment. It can be personalized. Despite what you hear from your doctor, from your endocrinologist, it can be personalized. There is not one size fits all. We can put you on NDT and then even add in a little bit of T3 to that, just to change that ratio, because NDT is roughly, and I say very roughly 80% T4, 20% T3. So when we're giving all that 80% T4, sometimes we have to add in a little bit of T3 to change you. Maybe you do better at a 70-30 ratio, at a 60-40 ratio. Sometimes it's just a matter of adding in T3 to your already existing Levo or Synthroid dose. And then sometimes you might be T3 only. So that's what I am. I'm actually T3 only. I do not convert. I need to do a genetic test to check those DIO1, DIO2s. But for me, it was a reverse T3 issue and then combined with trial and error. So of course, I didn't want to believe that I was T3 only, because we like to have a little bit of T4 in the mix. It's like your savings account. When you're talking about T4 and T3, you're talking checking and savings. T3 is checking. You're always drawing from your checking. It's there. It's fast acting. You spend it. Your body uses it. It's done. T4 sits in savings. It's something your body can pull from when it needs and then convert it to T3. Well, I didn't have any savings and that bummed me out. So every so often I would self-experiment. I would put in about 25 micrograms of Synthroid just to see how I would do. And every single time I would gain 10 pounds in a week. I do not convert. That T4 makes me go hypo. It brings all those hypo symptoms back, and it brings them back faster than what my reverse T3 would change to. So we see in me and in some of my patients too, that are truly T3 only, we see those hypo symptoms come back well before the reverse T3 goes above 12, because that reverse is climbing, but already you're 10, 15 pounds heavier by the time you actually go for lab testing. So some people are T3 only, but that's a very, very nominal number. It's very small in the percentage wise of hypothyroid patients who are truly T3 only candidates, we'll say. Most people do very well on T4 and T3. It's just the matter of, what do you need? What's your dose? What's that sweet spot? Just like all the changes that you went through, it's finding what's going to work for that person. Yeah. Individualized, personalized medicine.
It's so important.
So important.
And I'm laughing because the only other friend I know that does well, and she talks openly, so I'm not disclosing any personal information. Elle Russ does only T3. And she talks about it all the time. She's like, I know it sounds weird, but this is what works for me. And I always say, listen, This is the power of bio-individualized medicine, or, we talk about precision medicine. I think that functional is kind of evolving into integrative precision medicine because it's really getting granular about what works. Like, I know for myself, I need both, but I think it's great that you've been able to determine that works really well for you. I'm curious, do you have any women in your practice or people you've interacted with that you suspect are using T3 because they are already thin and want to be thinner? Like this body dysmorphia T3 phenomenon that I'm starting to see, because people, it's interesting, running a podcast, I'm sure you get this too. People write things. I mean, people want to overshare sometimes in emails. And I appreciate all my listeners. So let me be really clear about that. But people will bring things to our attention. Have you seen patterns that suggest X? I haven't seen that in my practice, but I would imagine that people that are dealing, solely in the thyroid realm probably are seeing people that abuse these medications.
Not as much as you would think, and not as much as I saw back in my bodybuilding days, for sure, where we know that there was abuse. I think now with the GLPs out, now I'm seeing the women that want to lose weight and get thinner. They're going to the Manjaros, the tirzepatide, the semaglutide. So they've kind of shifted away from the T3 use and jumped over to the GLPs.
Yeah, it's interesting. I've had a couple experts on talking about GLPs, and it's funny how I think when they work well for people, they work well. But then I tend to hear from the people who are like, I got constipated, I couldn't have a bowel movement, and I was nauseous 24/7, like nauseous, like when I was pregnant, nauseous. Mm-hmm. And so I think for every, fad or trend that's out there, there are going to be people that it just doesn't agree with them. But I do know from colleagues that I talk to that there's definitely pockets, probably not unique to the United States, probably everywhere now, but people who are like, just want to be thinner. They're already thin, but they want to be thinner. And this is the way they get to a point where they're eating next to nothing and they have no appetite. And so they're not even wanting to eat. And so we could have a whole separate tangential conversation about that.
Right.
But I know because of your bodybuilding background, let's talk about why it's so hard for women in middle age to build muscle. Because I think this is a source of frustration, for many of us. I include myself in this. Years of oral contraceptives. No one ever talked to me about the fact that being in that low estradiol state for years and years and years, I missed out on those peak bone and muscle mass building years. And so having to work a lot harder at this stage of life than I would have had to do when I was younger. But what's happening to our bodies that makes it harder to build and maintain muscle at this stage?
Testosterone. So with women, as we age, it's very important to remember that testosterone is actually the most abundant hormone in our body. Men have more of it. We know that. Obviously, they have more testosterone, but it's the most abundant in our body. And it's forgotten because it's seen as a male hormone. So your normal conventional doctor, or even conventional OBGYN, if you go in and you ask for a hormone panel, and this actually happened to me, I kind of tested it out with a PCP I had years ago. I asked for a hormone panel. I got a lab order for estradiol, FSH, and LH. Didn't even put on progesterone on there, and certainly didn't add testosterone. But testosterone is vital to so many things that we do. Libido, motivation. I call it the get stuff done hormone. You're not going to want to do anything unless you have adequate, optimal levels of testosterone. And then, yes, there's the muscle building aspect. I see that all the time. It's one of the main complaints that I see on an intake form of patient symptoms, weight gain being at the top, fatigue, and then, yes, loss of libido and loss of muscle mass, or the inability to put on muscle, is absolutely on there. And that comes down to testosterone. And here's one of the big issues too, with our standard lab value testing. Most labs will cut a woman off in their range at 48. So when we're looking at total, not your age, but the total testosterone, 48 is the last number of the range, the top end of the range. In my world, you're not even optimal until you hit a total testosterone of 50. Now we're going to look at the free testosterone. We're going to look at your sex hormone binding globulin as well. But that total testosterone, you're not even optimal until you hit a number of 50, which means you have to be flagged high in order to even be at the bottom of the optimal range. And that's where you're going to start noticing changes in your symptoms. Now, some women they'll say, listen, I'm a rock star. My total testosterone is a 45. Okay, that's fine. There's that unique pocket of women that get optimized at a lower number. But I got to tell you, I never see a woman with a testosterone of a 20 saying that she feels fantastic. It's always all of those symptoms listed out. And really for putting on muscle, I got to tell you, as much as I used to compete in bodybuilding, I used to compete in powerlifting. I mean, I was pretty strong for my height. I'm 5'2". I was strong, but I have never had the muscle shape and definition until now. And I'm 49 years old. And I'm talking competing in my 20s, right? Where your hormones are supposed to be perfect and you're at the prime of your life and you're athletic and strong. Now, at the age of 49, now that I've gotten all my hormones straightened out and optimized, and I'm on everything, I'm on testosterone, I'm on estradiol, I'm on progesterone. Now I'm seeing the reward for my efforts. Now, when I go to the gym, I'm like, oh yeah, there's those striations and a little bit of bulk in my biceps. This is awesome. This is what I was going for 20 years ago and couldn't achieve. Well, of course, I wasn't testing my testosterone levels in my 20s. Who knows? They could have been in the tank back then. Testosterone starts to decline in a woman really in her 30s. I mean, I have a lot of 30-year-olds walking around with testosterone levels in the toilet, sometimes a 3. I've seen a 2, I've seen a 3, and I've seen not even detectable testosterone numbers in females in their 30s and 40s, and definitely 50s, 60s, and above.
Well, and I think the other thing about testosterone, it's the get shit done hormone, which people just solely attribute it to libido. And I remind people it helps with body composition and lean muscle mass and all these other things. But we don't often talk about the fact that, if your testosterone's low, sometimes it's genetic, sometimes it might be a SNP. I mean, I've had women that have had very low testosterone levels. And I'm like, we actually need to do some genetic testing. But it also can be exposure to endocrine mimicking chemicals. It can also be latent insulin resistance. And I hate to keep harping on this, but when we know only 7 to 8% of the population is now metabolically healthy, it really becomes problematic, helping people understand probably a larger issue for men because they have more circulating testosterone. Ours is more potent, but I think it's really interesting, especially for you being in that bodybuilding space, that you noticed that now that you have more optimal levels of sex hormones, that now you're actually seeing the results you had been trying to achieve when you were a younger woman. And I think that's really interesting. I find for a lot of women, the issues with sarcopenia really accelerate north of 40, the pancake butt. I mean, these are things patients say to me. I don't talk about pancake butts, but they'll say I used to have glutes. Now I have a completely flat rear end. I have no definition in my shoulders, helping them understand that it can also be exacerbated by like the wrong types of exercise. How many women are you seeing that don't lift, or they don't lift heavy enough, or they're doing too much cardio, or they're over fasting, or they're still stuck in this mindset because we've conditioned our patients to believe that they need more carbohydrates and very little protein. And if you think that's going to change body composition, it really isn't. It's when I can get women to understand the importance of protein and to really prioritize that. It's amazing how everything shifts. And the other thing is, looking at the research and helping women understand that as our estrogen levels are falling, so latter stages of perimenopause, early stages of menopause, that loss of estrogen combined with high FSH, so follicular stimulating hormone, will accelerate this catabolic impact, the breakdown of muscle. And that's another reason why you have to be eating enough, I almost said enough muscle, enough meat and enough animal-based protein in particular to be able to offset what is happening in the body. I mean, I take Pilates, once or twice a week, and I kind of look around the room. There's another nurse practitioner that's in there with me, and she's become a really good friend. And I always say to her, I'm like, I look around this room and I'm like, these women are tiny, but they're all so sarcopenic, but they don't see it because in their minds, they're still small. We'll get messages from people that will say, oh, I don't have a problem because I'm still a size 0 or I'm still a size 2. And I'm like, I can pretty much guess that you have a loss of lean muscle and an increase in adiposity in your body, even if you haven't gained weight or changed, the size of clothing that you're wearing, but really helping women understand that muscle mass that we lose has catastrophic impact on our health.
Definitely. Yep. 100%. I see it as well. And these are the women that they'll complain about not being able to put on muscle. And listen, I was a cardio queen too, especially when I was competing. That's what you did. You did cardio twice a day. But these are the women that they're struggling, and it could come back to their thyroid. They're struggling so much that they overdo. They don't eat enough. They don't eat enough protein. They don't lift heavy because they want to get on the Peloton and go to town on that just to burn fat. And they haven't been educated that, lifting heavy weights is actually going to burn more fat and make you look better than jumping on a cardio machine and staying on a treadmill for an hour like a hamster on a wheel. It's not going to work, and you're actually going to end up burning your own muscle tissue. So if you look at the scenario, let's say someone has a thyroid problem, they can't lose. They get frustrated, they reduce their calories, they increase their intermittent fasting, and they go to town on cardio. Well, there you go. There's the perfect scenario for muscle loss. So now you have the muscle loss, the sarcopenia. Now you have the low testosterone as well. And it's just downhill from there. It's only going to get worse. Now you're looking at, as you age, the increased risk of fractures because you don't even have the muscle to support your body and protect your own skeleton. So it can cascade into a multitude of different disease states and issues as we age, but it really starts back at, we need to optimize your thyroid. We have to get you eating enough protein. Don't do so much damn cardio. Go lift some heavy weights, and let's optimize your hormones too, and you'll be good. Yeah. It's that simple.
Yeah, it really is. It's important for people to understand that. Now, on the other side, weight loss resistance, huge problem, probably not unique to either of our audiences. What are the needle movers in your estimation? Like, I was down a rabbit hole. I'm creating a course right now. And so I was like, okay, weight loss resistance, what are the big needle movers from my perspective? But I'm curious, what are the things, you talked about T2, we talked about weightlifting, what are optimizing protein? What are some of the other things that you found have been needle movers for your patients?
Addressing insulin resistance. I love berberine for that. I really do. I think it's as good, if not better, than metformin. I've done a couple of podcasts on that, just comparing the two and comparing the studies. So I love using berberine for insulin control, addressing adrenals as well. I don't go down the rabbit hole of adrenal fatigue a lot because I think that's an overused term, but you do have to look at what is the stressors in a woman's life? What is she dealing with? What is her cortisol pattern through the day? And I say pattern because it's not a one-time test. This isn't that you're going to test your cortisol in the morning via blood and get that one picture and know what's going on with your adrenal function. You're just not. So after we do a 4-point saliva cortisol, we get that whole picture through the day. That's important. And then cortisol will tie back to what we were talking about earlier, that reverse T3. So dysregulated cortisol, either too high or too low, will come back and start to push up that reverse T3, and it will put your body into a survival state. And this can happen whether you're diagnosed hypothyroid or not. You can have an elevated reverse T3 at any point of time, even just your own thyroid hormone production, the thyroid hormones that your thyroid produces, T4 and T3, T4 still has to be converted. So we can see an elevated reverse T3 with dysregulated cortisol. And then we look at there's so many things with weight loss resistance. So it's going to be thyroid, insulin, testosterone, adrenals. And then we can after we breach those, then we can go down different rabbit holes of maybe some food sensitivities, maybe heavy metals, maybe mold. But I don't even start peeling that onion until we deal with the basics, until we get your thyroid optimized, your testosterone optimized, your estradiol and progesterone optimized too. I don't want to forget those hormones because we don't want you to be estrogen dominant. That's going to produce weight loss resistance too. Reduce the toxins, get you eating right, get you exercising right, balance your insulin, and then we can go out here into all these other things that you hear the functional world talking about. I don't think we start with mold. We don't start with heavy metals. We start with the basics. We give you that metabolism first. And then if your body still says, yeah, no, I'm not going to release this fat, then we figure out, okay, why? And we start looking at all the other things.
I think it's really important to have kind of a comprehensive mindset about all those things. I find that one of the things that a lot of people forget about is just NEAT. So this, non-exercise associated thermogenesis. So walking, zone 2 cardio, which is really not even like cardio, but just being active throughout the day. I think a lot of people, go to the gym and they work really hard and then they sit on their butt for 9-10 hours and they wonder why their weight loss resistance. I mean, the other thing that I've started to kind of explore more, and obviously I am not an expert in this area, but reverse dieting. So for the people who have gotten themselves, they've whittled their diet down, they're not hungry for more than that one big meal. The people that are the chronic OMADers as an example, and I'll say them, how do you get enough protein in one meal? I know I can't. It's not a place of judgment. I'm just saying, how do you do that? The concept of reverse dieting, is that something that you talk to your patients about if you see through their intake that they're not eating enough food? And I'm not even talking about calories. I'm just saying, you look at it and you're like, that's not enough food to sustain someone's life. And you've now gotten into a situation where your body is becoming increasingly weight loss resistant because it thinks you're starving.
I see it a lot because of out of the desperation. These women, once they get to me, they've done it all. They have destroyed their bodies. They have tried everything under the sun to lose weight. So absolutely the starvation principle applies here. And they're not truly starving, but they're, just like you said, they're eating so little. They're eating so little that their body is in that true starvation mode and is holding on to fat for dear life. Usually we'll see their leptin levels really low. Sometimes they'll even have a very low insulin, like a 1, a 2, very low insulin levels, which is not for them, not correlated at all with being healthy, with being in control. It's correlated with them starving themselves. So yeah, absolutely. And that reverse dieting we would do after a show. So again, back to the bodybuilding days, after you depleted yourself and restricted yourself, sometimes to just a stupid level. I mean, we were not the smartest group of people doing these competitions. I mean, there would be some that would diet down to eating 800 calories a day, 1,000 calories a day. That's not healthy. Okay, you step on stage for one moment in time, then you walk off that stage, and now what? Now you're craving all those things that you didn't get the last 12 weeks. Your body is literally rebelling against you, and you have to reverse diet or you're going to put 40 pounds on in a week. And I have seen it happen. I have seen people blow up after a show. So yes, that reverse dieting principle comes from back in the bodybuilding days again, that we have to do something, and it's not going to be comfortable, and it's going to be just a mental screw for you to eat more in order to literally build your metabolism up from the ashes. We're bringing it back from it being dead. And in order to do that, you have to eat more food, the right kinds of food, obviously, but yes, you have to eat more food.
Yeah, I can imagine. Cause I feel like, obviously that's an extreme, the bodybuilding coming back from 12 weeks of restriction and intense training. But I think a lot of people that are in the fasting space, they'll say to me, every time I break my fast, I binge. And I'm like, then you're fasting too long. Because what people don't realize is you've got this primitive premortal brain. The amygdala overrides the prefrontal cortex, and your prefrontal cortex is like, I'm the executive thinking part of the brain, but the amygdala has overridden my thinking part. And I'm just thinking that I'm starving. And so that starvation response is significant. And I think that for a lot of people, it's with the understanding of, did you fast too long? Are you fasting for your menstrual cycle? Is there too much going on? Certainly I remind people, if you're going through something traumatic in your life or something stressful, that's not the time to add more stress by fasting. Maybe it's the time to have a 12-hour feeding window. Maybe it's time to do more rest and don't go to the gym every single day. And I think, for many people, they get so fixated on that one metric, which is weight loss, instead of understanding that their body, you have to get healthy to lose weight. Ben Azadi says that all the time. You have to get healthy to lose weight. And part of that is a healthy mindset, because I think for so many of us, it's that one metric that people get fixated on, and they're so rigid and dogmatic that everything else in their lives could fall apart until they step on that scale and they see that number that they have identified is their success number. And I sometimes will ask women, like, what's your happy number? Because if it's evident that there's a lot of a lot of focus on the scale. And I'll say, okay, I don't want you weighing yourself every day. I don't think that's healthy for you. Just like some people don't do well having an Oura ring, or they don't do well having an Apple Watch because the metrics. I'm a data nerd. I don't measure myself more than once or twice a month because I can generally tell by the way my clothes fit. Do I feel bloated? Nope, I feel pretty good. My clothes aren't tight. Okay, this is good. But for other people, it's that they will live and die by that scale. And I think it can be profoundly destructive. And in many ways, I think it doesn't serve us as women because the scale doesn't represent, unless you have a special scale that gives you a sense of body fat and hydration and all those things. Most scales, you step on the scale, it just tells you that's the number. That's where you are today. And our weight can be up by 3 to 5 pounds day to day, just based on what we're eating and what we're doing and how hydrated we are. And so I always say the scale is a liar.
Yeah, I would agree. Yeah. I'm the same as you. If I feel good, that's all that matters. I might step on just to see, hey, kind of where it as a baseline marker, like, hey, this is where I'm really happy because I feel good in my clothes. And okay, this is a good number. But other than that, I can't weigh daily. And I don't recommend my patients to do that either.
No, I think it can be destructive. Well, let's kind of end our conversation talking about one of my favorite supplements, obviously creatine monohydrate, which I know you're a fan of as well. How does creatine impact thyroid function, and how do you utilize this with your patients or yourself personally? What have you found to be most effective?
I love creatine. And again, it's kind of funny. We didn't really plan this conversation to continually go back to my bodybuilding days, but it keeps getting pulled in. I remember back in, oh gosh, this is the late 90s now, when there was the EAS Body for Life contest, which I did, my sister did, my dad did, we all did together as a family, these before and after pictures, and you had to use their products, right? And creatine was one of them. Well, my sister's a physician, so she wanted to do her due diligence and really look into creatine. Is it good for you? Does it have any side effects, anything? And that was the one supplement that had nothing but positive benefits associated with it. There was literally nothing she could find that correlated creatine with anything bad in the body, side effect wise, nothing. Some people back then with the type of creatine we were using would hold a little bit of water. So you get a little bit of water retention, but that's because of the mechanism of action of creatine, literally shuttling nutrients into the muscle cell and providing more energy, providing more hypertrophy of that muscle tissue. So I've been a fan of it for decades now, literally decades, because I think we can honestly say it really is the one supplement that has been out for decades that has nothing tied to it in terms of negative effects, negative consequences from use. So I'm a huge fan. And I try to get my ladies to understand that, and I think it is being pulled more into the regular market, out of the bodybuilding world, out of the sports supplement world, and into the, hey, let's use it for day-to-day function, day-to-day benefits in terms of our audience. And women are slowly realizing, and especially with your education of creatine, with your audience, realizing its importance, realizing the benefits, realizing that this can produce a little bit better workout. Like, yeah, those 5 push-ups that you did that you thought that number 5 was really hard. Now you just banged out 7. And maybe 2 weeks from now, it's going to be 10. And you just went from 5 pounds to 7.5 and then to 10 pounds. So those little incremental strength changes, that's going to come back and obviously benefit. When we lift heavy, we improve our testosterone and our growth hormones naturally, or levels naturally. So the creatine gives us a little bit more strength. We're stronger in the gym because we're lifting heavy. That's going to come back and improve our testosterone levels. That's going to come back and improve our growth hormone levels. Now, what do we know about testosterone? It actually has a feedback on the thyroid, specifically with Hashimoto's, to lower Hashimoto antibodies. So all this talk about testosterone, I didn't mention that another benefit of it is to lower Hashimoto antibodies. And we see this documented in studies. Of course, they were done with men, but we see it across the board in women as well. When we optimize a woman's testosterone levels, her antibodies also go down, and just that whole inflammatory response of the body goes down, and the thyroid works better. The thyroid is going to work better when all of your other functions in your body are better, when your sex hormones are better. The thyroid's going to work better when you're not inflamed, when it's not getting beat up by those antibodies on a daily basis. It is going to work better. So yes, we can absolutely say that through that pathway, creatine is beneficial to the thyroid. And then there's just the other benefits of creatine, improving nutrient absorption. Like we said earlier, shuttling those nutrients into the muscle cell. I mean, you've talked so much about it. I need to go down some more rabbit holes of creatine because I just mainly recommend it. And I just tell people, hey, start on this. Here's the benefits. But I know that you've even dove into anti-aging benefits of creatine, brain benefits of creatine, right?
Yeah. And even mood and cognition. I mean, the thing that's been interesting. So, I think it's important to get real life testimonials. And the things that I always find amazing is people saying to me, I've had long-term depression. I'm on medication. Within 3 days of taking creatine, I feel like my mood is lifted. And I always say, don't stop anything you're doing. Talk to your doctor. Like I'm always like, don't change anything. But I think that's wonderful. And I think it really speaks to mitochondrial health. It really speaks to ATP production. It really speaks to all of these cellular mechanisms that, people can tangentially, they're like, okay, I lift better. I lift heavier in the gym. I'm sleeping better. Like it can help with sleep architecture. My mood is better. And so people focus on that, but I always say it always comes down to the same things: mitochondrial efficiency, ATP production, cellular, like getting down to the cellular level. I mean, all those things are so important. And I think in a sea of the supplement industry that in many ways I think is well intentioned. Let me just be really clear. Well intentioned, because I come from a glass half full kind of, I'm a glass half full kind of person. But I think in many ways, like if you really go down those rabbit holes and really spend time, like I know you have with your own supplement line, that things can be very, very helpful. I'm like, let's simplify things. Let's not be on 50 supplements. Let's be on a curated amount of supplements that we know are very helpful. My entire family actually takes creatine, which I think is hilarious because people will say, is it safe for teenagers? And I was like, I have two very athletic teen boys. And you would ask my 15-year-old, he took it with him to where he's at a university doing a program right now. And he took it with him. He's like, I stick it in my water and I carry around my water bottle and I get to take it. And so I love that we both have this shared appreciation for creatine monohydrate. Misinformation on social media. I have to believe that individuals are well-meaning, but sometimes, Amie, it is so hard because it's so clear that these individuals, I'm not going to call them out, don't know what they don't know, and they don't know what they're talking about. Like, let's talk about the basics. Like, there are a lot of people that don't understand basic thyroid physiology. And I can imagine, because that's such a huge focus of your work, that must be incredibly frustrating. So let's start the conversation there today.
Yes, I also want to pull my hair out. And I talk about this a lot on my podcast too. Even going into and looking at the functional medicine, integrative medicine, alternative medicine, whatever category you want to put it under, we know that, okay, it's hugely beneficial to people, especially in this day and age, to have the opportunity to see a functional or integrative specialist, or even to listen to biohackers who have dove into the science. And it's bringing us out of that conventional medicine model where one size fits all. For the thyroid, all we do is test TSH, all we give is T4. So it's breaking out of that mindset, which is fantastic. But when we're talking about the thyroid, or when we're talking about hormones, those are so nuanced that you really have to know what you're doing to specialize in it in order to be able to have a full, accurate discussion, or to give the world or everyone on Instagram information about it that is accurate, that will benefit that individual. And too often I see in this world of biohacking, of functional medicine, it's kind of like a one size fits all cover in the functional world, where someone might be a peptide expert, but they're talking about thyroid and they're getting it wrong. And this is where I cringe. I'm like, oh no, 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 don't listen to this person with that. You can listen to them about peptides. You can listen to her about the gut, but don't listen to them when it comes to the thyroid, because that very much is a nuanced art, and you have to specialize to really know. And just like I don't sit here and claim to be a mold expert or a heavy metal expert or a parasite expert. I don't specialize that in my practice. I don't claim to be one. I don't talk about it because that's not my area of expertise. it's kind of the same feeling that I have in this functional world of like, please don't talk about it if it's not your area of expertise, because we want to ultimately give accurate information that help people, to help people move the needle, to help people with their symptoms, to anti-age, to protect their health long term in moving into perimenopause and menopause. We don't want to give them, and I hate using this term, especially coming out of COVID, we don't want to give them misinformation, but we don't. We don't want to give misinformation, because then people just end up very, very confused and usually paralyzed in making a decision for their own health, and they don't progress because there's too much info coming at them.
Yeah. So it's interesting. My husband, in the past 6 months, started thyroid medication, and he was listening to a male in the space talking about this individual's interpretation of how thyroid physiology works. And so my husband, who's an engineer, and for anyone that's listening that has significant other, loved one that's an engineer, you understand what I'm saying, that they are very quantitative, detail-oriented individuals. And so my husband came to me and showed me this video, and I said, that's actually not accurate. And let me show you why and how this works. And so that was number one. That was the first introduction I had to this individual's work. I think I texted you immediately because I was like, what is this clown doing?
Yeah.
And then it was multiple iterations of looking at other content that this individual wrote. What's interesting is there's another individual, again, who will remain nameless, was basically shaming women if they took hormone replacement therapy because, and this incorporates also thyroid replacement, because if you're doing lifestyle right, air quotes, you shouldn't need it. And all I could think of was, what kind of disservice are we doing to the health and wellness community if we don't understand what we don't understand, number one. And number two, we're propagating misinformation, because there are many people, myself included, I'm probably you as well. I would not feel as good as I do if I were not taking thyroid replacement, number one, and I were not doing HRT. But how many other individuals listened to this information and either felt shame about wanting to take hormone replacement therapy in any capacity, or the other individuals who were being told by healthcare practitioners that they, qualified for thyroid replacement, but then completely discounted what their provider said because of this individual who doesn't understand basic thyroid physiology. And so, out of respect for these individuals who I have to believe are well-meaning, I thought to myself, I was like, I think it's so important to just encourage people to do their due diligence and to understand their bodies as much as possible so that they can navigate making choices that make sense to them, that are in alignment with their goals. I had a guest on the podcast very recently, and she said, hormone replacement therapy is not right for everyone, and that's okay. And so that always should be the message, is that it might not be right for everybody, but everybody should be able to be counseled on the cost benefits, with either choice. If you choose to take it or don't choose to take it, understand what the long-term ramifications can be or not be. And that's what I hope, and certainly with this podcast, is exposing my community, certainly your community, to good information so that they can navigate good choices for themselves long term.
Yes, absolutely. Okay, there's so much I want to say to that. First of all, whenever I hear that kind of information, I always ask, is it a male? And the reason why I say this is because
Times two.
most men do not get hit with the amount of symptoms that women get hit with. And, your husband is kind of outside of the box. And men who have a thyroid problem are just near and dear to my heart, because it's so rare. And we know it starts affecting their quality of life and their testosterone. And so I love helping the guys with thyroid problems. But when I see an individual speaking about thyroid issues and giving the message that you don't need thyroid hormone replacement, it's you have to fix your cells, or you have to do better with your lifestyle, I go, have you ever gained 20 pounds in 2 months? Has your body ever totally rebelled against you to where you don't even know who you are anymore? Have you ever been so tired at 2 p.m. that you have to stop your day and lay down, even if it's for a 10-minute nap? Have you ever gone through that? Because if you haven't, please do not stand up there and tell me that I don't need thyroid hormone replacement when that could make or break my quality of life and protect me in years to come from a variety of different disease states that can come when your thyroid's not functioning properly or when we're not replacing with hormones. So that's always my first question is, have you walked in those shoes of having hypothyroidism? Because if you have, then maybe you can speak. But if you haven't, I'm sorry, you don't know what it's like. So that's really, I guess, number one is, I would say to any of your listeners, always look at the source. And then we have to go one step beyond that too and say, and I say this even with hormones too. When I hear someone say you don't need hormones, just take XYZ supplement and do this lifestyle or do my XYZ program. I always go, well, maybe it's because they can't actually prescribe hormones. That's not part of their program. Maybe they can't prescribe thyroid medication. So for their life, their business, basically, they have to come up with a protocol and give the messaging that you don't need it, because otherwise no one's going to come to them and do their program, because there's not that thyroid hormone replacement involved. There's not hormone replacement involved. So I also go one step further and I go, okay, maybe your program, I mean, works fantastic for people with gut issues, but it's not going to magically bring back their thyroid. It's not going to magically turn on their ovaries to produce estrogen at the age of 50. It's great for what it's great for, but don't expand that and give people the false message that they're going to anti-age and magically produce more thyroid hormone or sex hormones from doing this program as well. So it's almost like looking at studies. You have to go deep and you have to look at who funded that study. What's the motivation behind it? What's the motivation behind this message? And to your point, I'm sure that these individuals are very well-meaning, trying to get the message out to the world on different things that we can do to biohack and to improve our health. But we do have to be careful, because some information can actually do more harm than good. And that's where we have to really be cognizant and look a little bit deeper, even as consumers and listeners, as to what that message is, who it's coming from, have they walked in those shoes that they're talking about, and what's the motivation behind it? What are they selling? What are their programs? And do those programs kind of contradict going on thyroid medication?
Yeah, it's such a good point. And it's interesting to me because neither of them can prescribe, number one. Number two, one of these individuals, we had a shared patient, and I had been telling this patient for 2 years, it is time to start thinking about thyroid replacement, hormone replacement therapy. And when she finally went on, she was a different person. She felt so much better. And this is a really great example. And I'm all about being positive on this podcast and spreading good information. But this is a really great example of why second opinions are important. Making sure the individual, yes, the lifestyle piece is so important. That is foundational. There is no question. You're not going to do better on HRT if you still eat a standard American diet, you don't physically move your body, you don't manage your stress, and your sleep is crap. Like, let's be clear. But on the other hand, I think that in so many different ways, women feel a sense of shame for taking medication. I know for myself, my nurse practitioner, like this is probably 8 years ago, said, you finally have declared yourself. I think it's time for thyroid replacement. And for 6 months, I was super stubborn and I was like, no, I don't need thyroid replacement. And then finally, I was so tired. I was like, I need thyroid replacement. And I remember it was like within 3 days, I felt like a light bulb had been turned on in my brain because I felt so much better. I had so much more energy. So let's pivot and talk about what happens when we don't have enough thyroid hormone over time. What is happening to our bodies? Because understanding that in every cell of our body, we have a thyroid receptor helps us understand why it's so important to make sure our thyroids are optimized.
Exactly. I mean, just exactly what you said. Every single cell in our body has a receptor site on it for thyroid hormone. Now, specifically T3 thyroid hormone. So if you have been diagnosed hypothyroid, you are on medication, which I have a little side note that I'll get to in a moment. If you are on medication, most likely if you're in the standard conventional medical system, you are on T4. So you might be saying, well, I am taking this thyroid hormone replacement and it's just not doing anything. I don't feel better. I don't feel anything that Cynthia just said. My brain didn't light up. Why am I even taking it? And that's where proper treatment protocols come in. But I want to back up and just address the medication piece because I get this question a lot from my patients, from my audience, that they don't want to take a prescription. And I understand that, but we have to separate out what is a medication that you don't really want to be on and can you do things to avoid it? Maybe those are the Band-Aid medications, statins, antidepressants, which I'm not saying no one needs an antidepressant, but they are often prescribed as a Band-Aid before getting down into the root cause, which very well could be thyroid dysfunction, which is triggering that increased anxiety and depression. Yes, we want to avoid the Band-Aid medications that are not necessary, but we have to put thyroid hormone and progesterone and estrogen and testosterone, we put those into the hormone replacement category, where we are replacing hormones that are no longer being properly made by your body. And to my individual patients who maybe give a little bit of pushback and just can't seem to break through that, I say, okay, if your child or loved one was suddenly diagnosed with type 1 diabetes and the doctor came out and said, you are going to need to give your child insulin in the form of a shot or the pump, it is a hormone that is no longer being properly produced by their body. You wouldn't say, "Ooh, yeah, no, I don't want to start my kid or my husband on a prescription," because the doctor would say, "Well, then they're going to die because this is a hormone that is needed for life." Now, will you die without thyroid hormone? No, not necessarily, not quickly, like you would without insulin, but your quality of life is going to decrease. And then getting into your point of how does the thyroid control everything? It controls everything. So you are definitely at an increased risk of type 2 diabetes, which we know that's basically the start of all-cause mortality. If we really look at it, metabolic dysfunction then opens the door for a variety of different disease states. Obesity in and of itself increases your risk of all diseases, cancer, Alzheimer's, everything, all of those diseases that occur as we age that absolutely will contribute to an early death. Start with obesity, start with type 2 diabetes. So we know that the thyroid literally controls our glucose regulation, how much insulin is being secreted by the pancreas, how we utilize our blood glucose, how we respond to food. I have seen carnivores come into my practice with A1Cs in the diabetic range, and they've been carnivore for years. And it all comes back to they've also been walking around with thyroid dysfunction or Hashimoto's for years it was either untreated or mistreated. And because of that, there's that perfect picture of how the thyroid literally controls your entire body. Brain function. I have had many patients come in and say, I think I'm getting early Alzheimer's. I go, no, you're not. Your thyroid's low. You don't have enough active thyroid hormone in your body to get to the receptor sites on your brain. So yes, everything is low and slow. When you think about the thyroid not functioning well, being hypothyroid, everything is low and slow, from digestion to brain function to mood, metabolism, hair growth, skin cell turnover, heart rate, blood pressure. It's all low. It's all in the toilet. So if your whole body is functioning at a very low level, then you can almost see the issues that are going to come. You can see that if we're not regulating our glucose, that can feed cancer cells. And we know that Alzheimer's is type 3 diabetes with dysregulated insulin. You can see that, okay, if my brain isn't firing and functioning, early Alzheimer's absolutely can occur. Heart disease increases with low thyroid function. So there are so many things that are tied to it that it will happen slowly over time. You probably will receive all of those Band-Aid medications as your symptoms continue, as your blood work looks worse and worse, as you move into a type 2 diabetic state, as your lipid panel goes in the toilet and you get prescribed a statin, as your blood pressure goes up and you get prescribed a blood pressure medication. You can see how it can happen, but it's going to happen so slowly that you're going to attribute it to aging. Your doctor's going to give you a Band-Aid. And unless you are aware and educated, like we try to do on our shows, you might even miss it and dismiss it and not even realize that it could be your thyroid. And it could be as simple as going on thyroid hormone replacement, the right kind at the right dose and the right combination that is for you, that gets you optimized. It could be that simple. And now you can go over, and now I'm going to tie it back to that statement I made. Now you can go over the Band-Aid medications and slowly get rid of them, because you didn't actually you weren't Prozac deficient, you were thyroid hormone deficient. And that's where it all ties together.
And what is it that's unique about perimenopause and menopause that seems to increase the incidence of developing hypothyroidism? Because we know that it is much more common to see an underactive thyroid as opposed to an overactive one.
Thyropause, which may or may not be the title of my next book. Of course, as you know, it's all up to the publisher, but thyropause. So I've actually defined that as after the age of 40, when your hormones crap the bed, your thyroid goes in the toilet. Like, that's my very simple layman's term definition of thyropause. But to break it down, as we're moving into perimenopause and menopause, our hormones decline. We know that. You can't escape it. Unless someone figures out how to age like Benjamin Button, you can't escape hormonal decline. As those hormones decline, we know that decline can trigger Hashimoto. So let me back up. When we're looking at hypothyroidism, low and slow thyroid function, 95% of that is Hashimoto's, which is autoimmune. And with autoimmune, there's this beautiful analogy that I absolutely love of a three-legged stool, whereas one of the legs of the stool, you have that genetic predisposition. The other leg of the stool, you have leaky gut. And to your point, who doesn't have leaky gut these days? And then that third leg is a trigger. Now, that trigger could be a massive stressor in your life. It could be pregnancy. Even though having a baby is very natural, it's a huge stressor on a woman's body. I mean, let's face it, your hormones are on a roller coaster. Your body is rapidly changing. Well, now let's take that into perimenopause and menopause, where hormones are declining. And as a woman moves into that stage of life, estrogen is literally on a roller coaster. We could test a woman one day and she's estrogen dominant, and we could test her the next day and she's estrogen deficient. Her estrogen is on this wild ride. And that's a huge stressor on the body. Losing progesterone, losing testosterone, huge stressor on the body. So that stressor, independent of life stressors that are also going on as we move into middle age, that stressor is enough to flip the autoimmune switch from the off position to the on position. And when that autoimmune turns on, that's where we will hear women say, it was after my second child. It was as I moved into my 40s that everything went to hell in a handbasket. I started gaining weight, losing hair, became fatigued, can't think anymore. Now I'm depressed. And it's that hormonal shift that literally triggers a thyroid condition. And my argument is that everyone, every single person walking this earth, male or female, at least at the age of 40, we always make everybody at the age of 50 go get a colonoscopy. Who really wants to do that? But at the age of 40, this should also be mandatory. You get a full, complete thyroid panel, and you do that every single year. And if you have symptoms, you do it more often, because thyropause is real and it can affect both sexes, but especially women.
Yeah, I think it's such a good point that we understand as we are losing our sex hormones, it has a profound net impact on our bodies. And I feel like a lot of women are symptomatic with an underactive thyroid for years. And this has a lot to do with traditional allopathic medicine. I am guilty of this, but I worked in cardiology, so I'll be very clear. I saw emergencies, which were generally not what we were managing. That was usually the ER and the ICU. But a lot of women are just getting an annual TSH, thyroid secreting hormone. When you think about, starting at age 40, the labs that are most efficacious have the biggest bang for the buck. Talk to me about your recommendations about thyroid labs specifically so that everyone who's listening can kind of write these down. And I had a woman DM me the other day that said, and this is a nurse practitioner, she went to her primary and said, I want to have a reverse T3. We'll talk about this. I want to have a reverse T3 done. And the physician looked at her and said, are you dying in the ICU? And she said, no. And he said, then there's no reason to do that lab. So let's start, let's talk about optimal labs to do to assess thyroid function. Let's say if we start this at 40, what are the labs you think are most important to ask for?
So, I usually give a laundry list of labs. So TSH, free T4, free T3, reverse T3, TPO, and TJ antibodies. You don't have to write those down. I'll break it down for you. But I want to even simplify it further. Because to really answer your question, what do we absolutely need to get? It comes down to two, free T3 and reverse T3. I actually don't even care if you get the rest. Because here's the bottom line. TSH is very inaccurate at diagnosing a thyroid problem. It is a pituitary hormone. It's secreted by the pituitary to trigger your thyroid to produce more thyroid hormone. If the pituitary senses and gets the message from the hypothalamus, so HPT axis, if the pituitary senses there's not enough thyroid hormone in the body to do its job, it's going to kind of poke and nudge the thyroid to make more thyroid hormone. So if TSH is elevated, that's just blatantly obvious. But the problem is that TSH can often look really, really pretty. It can be within the normal standard lab value range, or it can even be in the functional optimal range, which is less than 2. But a person can still suffer from hypothyroidism. So my fear in even giving TSH out is that doctors will just rely on that. So despite what your free T3 and reverse T3 say, which we'll get into, they're going to look at that TSH. It's going to be a 1 and you are dismissed. There's no way you could possibly have hypothyroidism because your TSH is within normal limits, WNL. I also have started to kind of push aside the free T4 because I even see this with my community. People start chasing free T4 levels. And this is very much tied back to the reverse T3 that we'll talk about. People start to chase free T4. And if they are on thyroid hormone replacement, they'll add more. They'll go back to their doctor and their doctor will give them, instead of 112 micrograms of Synthroid, they get 125 and then they get 150 and then they get 200. And they're chasing this free T4 lab value to get to a certain range. But then when we look a little bit deeper at the most important labs, we see that reverse T3 goes up. So let's break that down. Just like you said, reverse T3. It is beautifully built into our bodies as a survival mechanism. So if we are in the ICU or the ER, and I'm sure you saw this when you were working, when you test someone's reverse T3, it's going to be through the roof. Thank God. Because at that point in time, they don't need to burn fat. They don't need to make major life decisions. They don't even need to poop every day. They need to lie there and survive. And all energy has to go to healing in that moment of time. But what if that reverse T3 is elevated? Our bodies think that we're lying in the ICU or the ER fighting for our life, but we're walking around trying to raise a family and run a business and do 10,000 errands in a day. We don't want to not function. We don't want our bodies to think that we're lying there fighting for our life. That's why it's vital to test reverse T3. And here's something, if you remember nothing, here's one thing to remember. The only thing that converts to reverse T3 is T4. So going back to what I said in the very beginning, so many people say, well, this thyroid medication isn't working. What are you talking about? I don't feel like Cynthia did in 3 days. If you are on T4 only, that T4 has two choices. It can convert to free T3 thyroid hormone, the active thyroid hormone, or it can move down this path and go reverse T3. Because that conversion of T4 to T3 is really hard for your body to do, and there's multiple factors that can interfere with it. Insulin resistance, estrogen dominance, low magnesium, low vitamin D, low selenium, genetic SNP. Because there's so many things that can interfere with that conversion, it's very likely that as you go up in your T4 medication, you're pushing more and more to reverse T3. Cortisol plays a role too. Who isn't stressed these days? So this is right.
That's the truth.
My gosh. So I see a lot of elevated reverse T3, a lot. And especially when people come to me from the conventional system where that's all they're on and their doctor just keeps increasing it. And one more thing I want you to remember. Here's a stat for you. 98% of those with hypothyroidism need T4 and T3, or some need T3 only. Only 2% do well on T4 only. 2%. And of that 2%, I would still like to argue, what do you mean do well on? Are these the people that just kind of accept being overweight and fatigued? And they're just like, yeah, I'm fine. And that's their new norm. I don't even know about that 2%. I would even argue it's possibly like 0.5%. You have that outlier that they're on T4 only and they're a rock star and they're fine. But the rest of us need a combination of T4 and T3. And it's mainly because of pushing to that reverse T3. So reverse T3 and free T3, the active thyroid hormone that actually gets to the receptor site on your cell and turns it on. If you only tested those two markers, we have a full picture. We totally have a full picture. Now, I don't want to leave out the antibodies. I know people are going to be like, well, what about the Hashimoto antibodies? You're not going to get treated any differently. I mean, yes, it's amazing to know whether or not you have autoimmune, because then you can be proactive. Autoimmune begets autoimmune. Where we see one, we see more than one. You can do those proactive things like eliminating gluten, which my argument is we all should be doing anyways, whether you have autoimmune or not. Like controlling your stress, which we all should do anyways, whether you have autoimmune or not. You can be a little bit more proactive to protect yourself. Maybe you go on low-dose naltrexone, add in black cumin seed oil, which is amazing for inflammation and antibodies. But at the end of the day, even if you had those tested, I don't know, once a year, that's fine. But I want that free T3 and reverse T3 tested often so we can really see how you are doing and how you are moving through midlife and whether or not you need thyroid hormone replacement.
This is like a mini thyroid masterclass.
It kind of is.
I'm
Yes.
loving this. I'm loving this. So, for listeners, understanding what you need to be advocating for, these are not weird labs, these are not unusual labs. I think that for every person listening, if you are optimized on thyroid medication, great. What I find is most women are not. They're kind of struggling in the in between, meaning they're taking medicine, they see a scooch of improvement. They have hope that they're going to feel better soon, but they still feel like they've been run over by a car every day. They're tired and fatigued.
Yeah.
And we talk about thyroid pause. I think this is important. Every hormone goes through this pause state. I've even heard adrenal pause. I think these are important to understand. It's not just our sex hormones that take a hit. And so, as someone who has Hashimoto's that has never had a positive antibody, I'm going to say this again. Most cases of hypothyroidism are attributable to autoimmune Hashimoto's. You do not need to have a positive antibody. But what I find interesting about antibodies, anecdotally, is that for a lot of women, it is sometimes the kick in the pants they need to stop eating gluten, because we talk about molecular mimicry. Let's talk about that, because when we talk about gluten or dairy or soy and that offsetting the receptor can help people understand, like, we're not just being mean by suggesting you go gluten-free. I think going gluten-free for me, prior to being diagnosed with hypothyroidism, is what put my other autoimmune issues into remission. It is that powerful. You can do it, I promise. I thought it was harder to go dairy-free, to be completely transparent.
Yeah, no, it's definitely harder to go dairy free. And do you know, I still reference one part of our conversation, whether it was on your podcast or mine, the last time we spoke, where you and I were discussing antibodies, and we both currently have zero antibodies. Our
Mhm.
antibodies don't show, but we both have Hashimoto's. And I always go back and I reference that because when you live that healthy lifestyle and you are gluten free, those antibodies can continually come back at zero. You can literally put your autoimmune into remission. Now, that doesn't mean that you don't need thyroid hormone replacement to address the actual thyroid hormones that we talked about and bring those into an optimal state, but you can put your Hashimoto's into remission. So here's the analogy I love to give with Hashimoto's, and this will tie in the molecular mimicry. I talk about antibodies like soldiers. So when you look at your TPO, thyroid peroxidase, or TG, thyroglobulin, when you look at those markers on your labs, it will have a number. Now, if you have a less than one, you can pretty much chalk that up to zero. But if it has a number, let's say there's 9, let's say there's 30, let's say there's 1,000, think of those as soldiers that are going out and beating up your thyroid gland, because that's essentially what autoimmune is. It's your immune system, very, very confused, thinks that your thyroid is a bad guy and likes to go and start a war and beat it up. Those soldiers, when they see a gluten molecule, so we have gluten containing foods, of that, the protein of gluten is gliadin. When we look at that microscopically, it looks in molecular structure very, very similar to the thyroid gland. So you have these soldiers that are programmed to think that your thyroid gland is a bad guy. Now you eat gluten. Now those soldiers see this thyroid like thing coming in and they go, I think we're under attack again. The invader is coming in. Let's go start a war. And they go out and you essentially launch your own attack on your thyroid. You are spurring on an autoimmune attack. Now, it might be something that you recognize and can feel. Oftentimes, I have had patients come back and say, okay, it was the holidays and I hate gluten.
And
And
I feel like crap.
man, I mean, this actually just happened to me over Thanksgiving and it surprised me a little bit. It literally surprised me a little bit. By Thanksgiving Eve, so we went out, we actually went to this beautiful club. I didn't cook. We went with friends, huge spread of everything. I mean, everything that you can imagine. So yes, I absolutely indulged in the stuffing. No, it wasn't gluten free. And yes, I had a glass of wine. And yes, I had the desserts and I tried like one of each because it's Thanksgiving and I rarely do this and it was a lot of fun. By that night, I thought I had MS. My
Oh,
entire
wow.
body from head to toe was locked down. I mean, I was doing these weird stretches, just trying to like loosen up my muscles. I took boatloads of magnesium. I was like, I couldn't even believe how my body was responding. And then, of course, my sleep that night was probably the lowest sleep score in tracking my sleep that I've ever gotten. So it can be an immediate effect that you feel, and actually, I find that a blessing because that gives you that immediate feedback to go, I will never do that again. But oftentimes, it's very, very slow and almost like insidious. Like I don't feel well 2 days out of the week. I'm on the couch. I'm in pain. What's going on? Was it something I ate? I don't know. And you're in eating that gluten, you are spurring on that autoimmune attack and your thyroid gets attacked. And not only that, but you start increasing the amount of soldiers. So you might find that if you don't go gluten free, the next time you test, well, now you went from 100 to 500. Now you went from 1,000 to 3,000. So you're building your army as well. And I think when we put it that way to people, it it gives them that kick in the pants that you're talking about to say, "Oh, okay, well in that case, I will cut it out because I don't want that to continually happen to me."
Yeah, and it's so interesting your experience on Thanksgiving, the degree of inflammation that must have been ongoing in your body. I went gluten-free 13 years ago and there were not nearly as many options as there are now, but I recall and we have a mutual friend Natalie Jill. I was like doing one of her workout programs and she was really big on like no gluten. And I can
Yep.
remember the amount of inflammation that I felt like I got rid of almost instantaneously within the first week of not eating gluten. And the fact that I had to restructure like a snack if I wanted to eat a snack or a meal was life-changing. And I say to my husband all the time, he doesn't eat a lot of gluten, but he does eat gluten. My boys eat gluten. Um, the differentiator for me was so profound that I was like, I'm never going back. And when I'm outside the United States, I can eat gluten and I'm fine. I think it has a great deal to do with dwarf wheat hybridization, exposure to glyphosate, what that does to the gut. I think it's why many people will say, I can enjoy gluten when I'm outside the United States, but I can't enjoy it here. I think it has a great deal to do with the way that we address wheat here in the United States, in silos so that it, lives on forever. That's why this hybridized form of wheat has been created so that it can sit in silos and not spoil. And yeah, that's great, but it's also why so many of us don't even think about the way we eat and how it impacts the way we feel. We've just gotten so conditioned. I mean, I grew up in New Jersey. I grew up at the Jersey Shore. And, I grew up in a childhood where there was a ton of gluten everywhere. And, I think about this now. I remember I went off to college and I would come home and my friends were like, you eat weird now. And I'm like, no, I just eat something other than like Italian food, which is fine
Mhm.
as a time and a place. But I think for so many of us, it's so much a part of our culture or our human experience that we eat exactly how we did as teenagers into middle age, and we start to realize it just really does not serve us. I would love to touch on medications because this is another area that I think a lot of people don't understand. There's lots of options. It's like going to the grocery store. You have like the conventional, you have the like let's just say that the formulations that have more than just T4 in them. We'll think about that as, we're having an upgrade. And then you can have compounded. You can run the gamut. I've met plenty of people that have done really well, or at least they tell me they're doing fine on Synthroid. I have others that have moved on to Nature Thyroid and that group of options. And then those of us that have graduated to graduate school, I always say like it kills me, but it doesn't kill me that I have to have everything compounded now because that's what works best for me. We've tried everything else. And if the generic stuff works, great. Don't feel
Mhm.
like you have to upgrade to the stuff that I'm using. But if it doesn't work for you, know that there's lots of options. So let's talk about the options that are available, both kind of conventional all the way up to compounded.
Oh, I love this because there are so many options. And when
Mm-hmm.
I get asked the question, well, what is your favorite thyroid medication? I say the one that works for you in the combination that's going to work for you in the dose that's going to work for you because we have so many options. And that's really the message that gets lost, definitely in the conventional system with their T4 only approach. But even moving into functional and integrative, again, if they're not an expert in the thyroid, I see a tendency to only give NDT medication, which is natural desiccated thyroid. So, natural desiccated thyroid medication, that's your ARMOR, your NP. And then we can even go into compounding T4 and T3 together. The problem with staying in that realm of thinking is that you could do a disservice to people, to your patient, because that NDT medication, it does contain T3. So now we're into that 98% of us need T4 and T3 or T3 only. Okay, NDT medication does contain T3. It's around 80% T4 and 20% T3. Now, if we're taking someone that's on T4 only and we move them to NDT, they're going to feel the difference because you're giving them some of that active thyroid hormone. So in the beginning, everyone is going to be like, whoa, this is amazing.
I
Yes.
couldn't sleep. That was my tell. I would get insomnia, terrible insomnia for like the first week.
With the NDT or with the
Yep.
T4? With
With
the
the
NDT.
NDT. Hmm.
Okay. So when you move into that, into NDT, sometimes you feel better, sometimes you feel worse, or you have symptoms that start appearing that you're like, wait, this isn't right. This isn't good. So that's where okay, we're not quite there. It's better, but we're not quite there. Now, the beauty of customization of thyroid hormone replacement is that we can start bringing things in to change the ratio. So if we move to compounded, well, we can tell that compounding pharmacy, you know what, instead of doing 80% T4, because this person has a reverse T3 that's kind of it's kind of iffy, don't like it. We don't want to give them too much T4. Let's bring that down. Let's do 40% T4 and 60% T3. So compounding thyroid medication, we can make it however we want to. We can do any ratio we want to. Or for people that maybe don't want that, we'll say extra expense because their insurance is covering the medication that they pick up at CVS, Walgreens, at the pharmacy. And again, there's nothing wrong with that. I'm on total generic T3 only, and it works for me. What we can do is take that NDT and bring in liothyronine or cytomel. That's T3. So liothyronine is the generic form of T3. Cytomel is the brand. Quite honestly, when it comes to T3, I like generic over brand because generic has less fillers than the brand T3.
Interesting. Yeah.
It's flipped with T4. T4, the generic, has more fillers than if you go up in kind of the stratosphere of Synthroid and then Tirosint and then Tirosint Sol. It gets more, for lack of a better word, pure as you go up that T4 ladder. But over in the T3 category, we can throw in some liothyronine to that NDT. And now we've changed the ratio. Now we've brought you to more of a 50-50, 40-60, whatever we want to do ratio to really tailor it to you. We can also move over here and say, okay, here's this person on Synthroid. They're doing okay, but their free T3 is low. So let's leave them on that Synthroid that they're doing okay with. Reverse T3 looks good. Obviously it's brought their TSH into the optimal range, but man, that T3 is still low and they have all the symptoms still. So now let's bring in some liothyronine to their thyroid protocol and adjust that as we go. And even to that, I get the question, well, what's the average dose of T3 that works for people? I said, I have people that are optimized on 10 micrograms. I have people taking 200 micrograms and then everything in between. It
That's
really
amazing.
is. And this just speaks to the nuance effect. It's so individualized and nuanced to you, but you can absolutely get to that optimized state in once you find the right person to work with and the right combination of thyroid hormone replacement that you need.
I think it's so important that you stress bio-individuality rules, how critically important it is. Certain people have certain budgets. They'll say, I need to use the synthetic options, and there's no shame in that. Other people are like, I've done the non-desiccated, and that doesn't work for me.
Mm-hmm.
I have tried everything. I actually did really well on Nature Thyroid, and then it became impossible to find.
Right.
Then I got put on Synthroid and Cytomel. Then that stopped working and they kept increasing my T3. And I was like, time out. I don't think I need more T3. Now I'm on compounded and that works really well. And because I've been stable for 2 years, I'm like, we're not going to mess around. It's everything. I feel good. I have plenty of energy. I know that in the realm of cofactors for thyroid replacement, there's a lot of controversy around iodine. What are your thoughts? Do you routinely test your patients for iodine deficiencies? Are you a fan of replacing iodine in appropriate patients?
I am in that camp of being pro iodine. And here's why. Number one, I interviewed Dr. David Brownstein, who really I put him in the camp of the guru of iodine because he has been practicing in the Goiter Belt of Michigan.
The goiter belt.
It's the Goiter. I came from the Goiter Belt too, up in Erie, Pennsylvania, all on the Great Lakes. It is the Goiter Belt. It's the Cancer Belt. So he's practiced for decades in Michigan and really dove into iodine. And this is decades ago when he was seeing a lot of his patients coming in with thyroid problems. And he'll say, I have no problem putting these people on thyroid medication. That's not an issue. But why? Why are we seeing so many thyroid problems? Now, I mean, 20 years ago, he was saying it was low iodine. Today, we could say, okay, low iodine and all the toxins and everything in our environment and the stress that triggers Hashimoto's or autoimmune. But going back to his research, he started using iodine with his patients and he was seeing an improvement in thyroid function, a decrease of doses of the thyroid hormone replacement that people would need. And you can go one step deeper and just really use kind of basic biology common sense. Every cell in our body has a receptor site on it for iodine. Iodine is amazing at being antiviral, antibacterial. World War II soldiers used to carry it basically for everything. Oh, you got a wound? Let's put some iodine on it. Oh, you're sick? Take some iodine internally. So that's why I can't wrap my mind around the other side who say, don't use iodine. I think you have to use it responsibly. So I really believe that iodine got a bad rap when doctors were, or practitioners were overdosing it. Like, yes, you need iodine. Here you go. Start off on, we'll say 25 milligrams of iodine. And some individuals went hyper. They went into a thyroid storm, and that's never good. But if you go low and slow with it and dose yourself very slowly to find your tolerance, then there's really no harm. You're only supporting your body. And I always tell my patients when we start them on iodine and they're slowly titrating up, say, you will know the day that you go one drop too many because you will feel anxious. You will feel hyper. You'll feel over caffeinated. You will feel it, but here's the good news. It'll go away in a few hours or by the next day. And now you know that your dose, you got to back that up and go 1 or 2 drops lower than that. And that's your sweet spot. And that's okay. Finding your dose of iodine is also very bio-individual. You have to play with it and go nice and low and slow to get to that level. Now, I don't actually test for it. And this came, so sometimes we'll throw in a test, but I always tell people, if you're not taking it, your iodine's going to be low. If you are taking it, it's probably going to be flagged high when we get that lab back. But I interviewed Barton Scott years ago, and we were talking about hair tissue mineral analysis. And I said, do you test for iodine in that HTMA? And he goes, no, because every cell in our body needs it. So why don't you just take it? And I just remember that quote. And I've hung on to that quote as it's so simple and so basic. Like, well, why don't you just take it? It's like, oh, okay, done. Put a pin in it. So that's my take on iodine. I have seen and heard people improve in days. So as we're working on optimizing their thyroid, they add in iodine and they're like, oh my gosh, I have more brain function and more energy. It's great. I mean, it can really turn the corner very quickly when you add in iodine properly.
Fun fact, my mom and my aunt are both patients of Brownstein's. So I'm very aware of his work. I actually have his iodine book sitting on my sitting in my bookshelf that I have skim read, but I do believe that depending on the individual, definitely a good option. Let's talk about what are you using that's new. I know that you've got an amazing supplement line. What are some of the new things that you are working on within your business to help optimize your thyroid patients? Not just the way they feel, but optimizing their lives, like making things simple. I know we're in agreement about keeping things simple or trying to keep things as simple as possible.
Yes, yes. The supplement fatigue, supplement
It's
overwhelm.
a real
I get
problem.
it. Right. So, well, what I do for my patients is I have what I call the no dust supplement. So I term that from, our days of childhood back in the 80s. Well, like, duh, of course you're going
Mhm.
to take that. So those are the no dust supplements. This is your vitamin D, your magnesium. I put iodine in there. I put creatine in there, like we discussed on my podcast. And I also put in there black cumin seed oil. And for thyroid patients, I put in T2. So I'll break those two down. So black cumin seed oil, it is part of my line. It's in Hashimoto's Fixer. But when I first released it, when I knew, okay, I know that black cumin seed has a boatload of evidence in lowering antibodies of all autoimmune conditions and lowering inflammation. So done. It wasn't until I released the supplement that I went even deeper into the research. Usually we do this before. It was good enough for me that it lowers inflammation and lowers antibodies. Boom. But then I went deeper into the research. And as you know, to be able to say anything is a cancer preventative or may actually protect you against cancer, you better have research behind it, or all the alphabet agencies will come after you and shut you down,
Mm-hmm.
right? And black cumin seed is one of the only supplements, ingredients,
You like flew under the radar?
compounds, right? That can actually say that.
Oh,
Yeah. There are a multitude of studies that show that black cumin seed oil is basically a cancer preventative. It helps
that's
reduce your risk
amazing.
of. So I have now put that because of it lowering inflammation as well. That extra benefit of being cancer protective, it's in my no dust supplements now. So I take it every single day. And you believe me, I loaded up on that Thanksgiving Eve and all the next day too, because my body was so inflamed from the alcohol and gluten consumption that I did that 3 times a day just to lower the inflammation.
Do
So
you
black
not
cumin seed for sure.
not to interrupt you, but just out of curiosity, because I know low dose naltrexone has some of those same
Mhm.
properties, and I know Dr. Pam Smith talks about I take 4.5 milligrams a day, and that's my therapeutic range. She takes 1 milligram a day for breast protection. So I'm
Mhm.
curious, have you seen like, do they feel like, I mean, I'm sure that you work with both of them. Do you feel like one is more efficacious in your patient population in looking at reducing inflammation? And low-dose naltrexone, let me just interject this, it's one of these weird drugs that you don't know if it's going to work until you use it. And so
Yeah.
some people you can use it and they don't per se see an improvement in their antibodies. They may not have a reduction in their inflammation, but when it works very well. And for me, it was the missing piece to get my thyroid optimized. Like we were like, okay, let's try this, just kind of throw it up on the wall. So curious for you, do you use them interchangeably? Do you feel like you're using more black cumin seed oil? I'm just curious.
I use them together often. So depending on a person's antibody level and if they have multiple autoimmune conditions as well. So normally where we see one, we do see more than one. So if they have multiple autoimmune
Mhm.
conditions, I'll stack them. So we use LDN and black cumin seed at the same time. The where I see the difference between the two, they're both fantastic. They're wonderful. You'll have that subset of people with on LDN who may experience insomnia no matter
Mhm.
what time they take it. Sometimes we'll say, okay, pull it back, take it in the morning, don't take it at night. They'll still experience insomnia, or they will experience increased cortisol. And I've seen that in a couple patients as well as colleagues report back to me, you know what, I can't take that because my cortisol increases. So
Hmm.
that's the only downside with LDN, or to your point, we won't see any movement with LDN whatsoever and how they feel and inflammation, pain reduction, antibody reduction. So that's when we'll either move over to black cumin seed or we just use them together because it's a powerhouse together too.
So interesting. And then you also talked about T2. Let's, for benefit of listeners, talk about the functions of T2. This is part of Thyroid-Fixer, correct?
Yes, yes, yes.
Okay.
So T2, I've been studying for about 15 years, researching for 15 years. It has 30 years of research behind it. And it is a thyroid hormone, but it doesn't work on the thyroid itself. So what that means is you could take T2. And the mechanism of action is that it increases your basal metabolic rate. So it works at the mitochondrial level, stimulates ATP, and increases basal metabolism. So the amount of fat and calories that you're burning at rest. It also browns white adipose tissue. So that's why we're jumping into cold plunges, is to brown that white squishy fat and make it more metabolically active, make us more insulin sensitive. That's what T2 does, but it does it all at the cell level. The benefit of this is that number one, it doesn't produce that anxious effect. So sometimes even when we start someone on T3, or if you've ever taken too much T3, you get pretty hyped up and anxious. T2 does not do that. And it won't change your thyroid lab values. So you won't go back to your doctor and have them pull a thyroid panel and go, "Oh my gosh, you're hyperthyroid now." And you're saying they're going, "No, I feel great. Like I finally have energy and I'm losing weight. So no, I'm not hyper at all." It doesn't have that negative feedback loop to shut down your own thyroid hormone production like thyroid medication does. And again, I'm not saying that to avoid medication that doesn't take the place of it necessarily, but if someone is on T4 only, or if you are on any thyroid medication, you're like, I'm not losing weight. I'm not feeling any better. This might be something to add in because you can get that symptom relief without affecting your thyroid lab values.
So interesting. I always love connecting with you. And like I said, this is like a thyroid mini masterclass. Please let listeners know how to connect with you, how to listen to your amazing podcast, get access to your supplements, learn more about your work.
Absolutely. So you can go to dramie.com, DRAMIE, really simple. And on there, you can book a call if you're interested in working together. We do prescribe to all 50 states and most of Canada. Also, the podcast, the Thyroid-Fixer podcast, Cynthia's been a guest on many times. We dive deep into this whole world of thyroid hormones and all the symptoms around it. So that's a great resource as well to dive a little bit deeper. And from that dramie.com site, you can reach my store if you're interested in Hashimoto's Fixer, Thyroid Fixer, like we talked about today. You can access it there, or you can go to betterlifedoctor.com and go direct to the store.
Love it. Thank you for all the work that you do, my friend. Hey, if you like this video, you guys are going to love this video, and I'll see you there.
We are trained in our education to really memorize certain aspects of science that get really applicable in treatment of disease, but not so much for prevention. And yet, as we go on, we start to open our eyes to the fact that many of these diseases could be prevented in the first place.